and I'm going to share my screen with you guys here. Okay. So first of all, can everybody hear me okay? And I can't see face. Okay, perfect, thank you. Awesome. So good afternoon, everybody, and thank you so much for everyone who's attending today's presentation. My name is Melissa Kucey, and I am the Antimicrobial Stewardship Pharmacist here in Regina. Today I'm going to be talking to you about penicillin allergies. And I had given this presentation a while back at one of the provincial monthly nursing meetings, and there was a lot of great feedback and a lot of interest after I gave that brief presentation. And so we had kind of thought that maybe I would give this presentation at a more larger scale and maybe a little bit more in depth. So initially this was intended for nursing staff, but then we did open it up to pharmacists as well. And so this is a bit of a hot topic lately, particularly in light of the syphilis epidemic around penicillin allergies, and specifically the efforts to try and delabel patients reporting an allergy to penicillins. And so the objectives for today's presentation are to go over the incidence of true penicillin allergies, understand the harms that are associated with carrying this label of having a penicillin allergy. I'm going to introduce a new penicillin allergy delabeling tool available on First Line, and then we'll also talk about cross-reactivity between beta-lactam antibiotics. So I think we've all come across a patient who has reported having an allergy to penicillin, and it's usually the classic story that they were told they were allergic to the penicillin. Maybe they have a sibling who is allergic and they assume they have the allergy. Maybe they had some sort of rash when they took the penicillin. Maybe they got a little bit of nausea. And often some patients don't even really remember the reaction that they had. And it is quite commonly reported. About 10% of the population will report having an allergy to penicillin. And the reality is only about 5% of these patients actually have a true IgE-mediated allergy. So that means that less than 1% of the total population have a true penicillin allergy. So the overall incidence of true penicillin allergies is relatively low, and the incidence of anaphylaxis from penicillin is far less common. It's higher with parenteral penicillins, and we'll see about 1 in 4 episodes every 10,000 administrations, and less with oral penicillin. So anaphylaxis from oral penicillin, we'll see about 1 episode every 200,000 administrations, and then fatality from that anaphylaxis is less than that. So of the patients who report having an allergy to penicillin, the vast majority, about 95% of these patients, can actually safely take penicillins. And this is for a variety of reasons. Number one, most commonly what gets reported is a delayed benign rash. And so likely this is a type 4 hypersensitivity reaction, which we'll talk about in a minute. And usually what the patient reports is they were taking a penicillin, and then after a couple of days, they broke out into a diffuse rash that was quite itchy and bothersome, but really no other signs or symptoms associated with that rash. And these rashes are not a true allergy. They're not IgE mediated, and they may or may not recur with re-exposure. So they're not necessarily a reason to stop taking the antibiotic, assuming it's not too bothersome for the patient, and it's not a contraindication to receiving penicillins in the future. The second reason why most of these patients who report having an allergy to penicillin can safely take penicillins is because even in the patients who had a true IgE-mediated allergy, this allergy wanes over time or decreases over time. We lose that sensitivity over time. So for example, about 80% of patients with a true IgE-mediated allergy, they will have completely lost that allergy after 10 years of no exposure. And the last reason why most of these patients can safely take penicillins is because they were never allergic in the first place, and what they reported was often either a side effect or maybe just a cutaneous manifestation of the virus itself. And there are consequences of carrying a penicillin allergy label, particularly if you don't have a true allergy. And we know that most patients, when they are labeled with a penicillin allergy, they don't undergo any evaluation or re-evaluation to determine the accuracy of that allergy or the persistence of that allergy. And this often leads to exposure to more broad-spectrum antibiotics that are potentially less efficacious and associated with more side effects. And in fact, studies have shown that when we expose these patients to more broad-spectrum antibiotics with lower efficacy, these patients have a threefold increased risk of adverse events. They have a 23% increased risk in C. diff infections. We see 50% increased risks of surgical site infections, 14% increase in MRSA infections, and 30% increased risk in VRE infections. So there is obvious harm to the patient and increased cost to the healthcare system. And this is just a bunch of studies that have proven this and essentially are outlining the consequences that I pointed out in the previous study. So these are studies that are showing, increased rates of MRSA infections, increased rates of C. diff infections in patients with documented penicillin allergies. There was even one study that found a higher mortality in patients having a penicillin allergy label. So we know there's increased harms in having a penicillin allergy label, once again, particularly if a true allergy doesn't exist. And so it's really important to reevaluate that allergy to determine the accuracy of the persistence of that allergy. And before we can talk about what that process looks like, it's important to understand or have a general understanding of the different types of hypersensitivity reactions that a patient can experience. And so the Jelen-Coombs classification breaks down the different categories of hypersensitivity reactions. And from a general understanding, penicillin hypersensitivity reactions can be separated into one of two categories. They can be separated into immediate hypersensitivity reactions, or type 1 hypersensitivity reactions outlined in red, or delayed hypersensitivity reactions outlined in green, and this is types 2 to 4. And the pathophysiology and the management of immediate versus delayed hypersensitivity reactions is very different. Our immediate hypersensitivity reactions are mediated by IgE antibodies, and it is these types of reactions that pose the risk of anaphylaxis upon re-exposure to that penicillin. And so this is what we classify as having a true penicillin allergy because of that risk of anaphylaxis. This is the IgE-mediated reaction that we are referring to. The delayed hypersensitivity reactions are mediated by different antibodies, and they don't carry that same risk of anaphylaxis upon re-exposure to the penicillin or to that antibiotic. And so that's why we differentiate immediate versus delayed. And so just to go into this into a little bit more detail, our immediate or type 1 hypersensitivity reactions, these happen within minutes to hours. And they are characterized by the presence of signs and symptoms of anaphylaxis, and that's certainly the most severe form of an immediate hypersensitivity reaction. A patient who has an immediate reaction can just break out into hives. Maybe they have some angioedema or associated swelling, and it can certainly progress to anaphylaxis. So anaphylaxis, as I said, is the most severe form, but immediate reactions don't always necessarily progress to anaphylaxis. And this is mediated by preformed IgE antibodies. And because these are preformed IgE antibodies, this requires some sort of prior exposure to the antibiotic for a period of time. And don't get hung up on the 10 days that I have up on the slide. When I spoke with an allergist about that, she had said, less focused around the 10 days, the point being they need to be exposed to that antibiotic for a period of time for your body to make these IgE antibodies. And it's extremely rare to have a type 1 immediate hypersensitivity reaction with a first course of antibiotics. And so what this means is a patient would have had to have a course of penicillin, they would have tolerated it fine, their body would have been making these IgE antibodies, and then they go home, they come back to their physician a couple months later with a different infection, they require a penicillin again, they have prescribed that penicillin, and then it's usually that first dose within the first hour that they have this immediate hypersensitivity reaction. On the flip side of that are delayed hypersensitivity reactions. These occur within days to weeks, but these also require some sort of prior exposure for the most part. They almost never occur within the first 10 days of the first course of antibiotics. If it is the first course of antibiotics and the patient appears to be exhibiting a delayed hypersensitivity reaction, often this is a situation where the patient has been on this antibiotic for a couple of weeks and they're showing signs of maybe a delayed reaction, in weeks 3 or 4, for example, so that their body has obviously been building up these antibodies. And most of these delayed hypersensitivity reactions are those type 4 hypersensitivity reactions that I alluded to before, and these are usually just benign, itchy maculopapular rashes that a patient will experience, and these rashes can last for a few days to even a few weeks and often don't have any other symptoms associated with them. So that is by far the most common delayed reaction that we'll see. There are more rare severe delayed reactions that can happen. So you can see things like hemolytic anemias, vasculitis, serum sickness, those types of things, but they are not that common. They are rare. And so some indicators or red flags that a patient might report that might indicate a more severe delayed reaction would be if the patient is reporting a painful rash, or if they had any type of mucosal involvement, if there was any blistering or skin peeling, if they had a fever of unknown etiology with an associated lymphadenopathy, or some sort of joint inflammation, or any other hepatic, renal, pulmonary, any other organ involvement associated with that course of antibiotics that can't be explained by infection. It could be a red flag that there was maybe a more severe delayed reaction that was occurring. So now that we have a general understanding of the different types of hypersensitivity reactions, now we can better understand what we mean by reevaluating or reassessing penicillin allergies and what that process looks like. So the most important piece when we're reassessing a penicillin allergy is obtaining a comprehensive history for proper evaluation. So these are asking questions like, what were the symptoms? And this is trying to differentiate, does this sound more like a side effect or more like a hypersensitivity reaction? What was the timing of that reaction? And once again, trying to differentiate, was this an immediate reaction or was this a delayed reaction? How long ago did that reaction happen? So the longer that the patient, the longer the reaction was, the more likely they are to have lost that sensitivity. So if it happened 30 years ago, the chances of them completely losing that sensitivity are greater. How is the reaction treated? So this is to gauge the severity of that reaction. And then has the patient tolerated similar antibiotics since that reaction? And if so, they obviously don't have an allergy. And so there are clinical pearls and things that you can remember to ask questions and assess if a true allergy is present. I think an easy one to remember is the 111 criteria. So for any patient reporting some sort of cutaneous reaction, asking the following questions. Did the rash happen after the first dose? Did the rash happen within the first hour? And did the rash resolve within 1 day of stopping the beta-lactam? If the patient answers yes to all of those questions, that has a positive predictive value of 90% in predicting a true allergy being present. So rash within the first dose, did it happen within the first hour, and did it resolve within 1 day? If yes to all of those, this is a very high likelihood that there was a true immediate hypersensitivity reaction or a true allergy present. But we don't have to remember all these clinical pearls necessarily, because there are really good resources and tools to help guide us in making these clinical decisions. And there's a new tool available on the First Line app. It's the Penicillin Allergy Delabeling tool. And for those of you who might not know or might not be familiar with the First Line app, so first of all, it is an app, but you can also access First Line on the website. It used to be called Spectrum and is now since changed its name and is now called First Line. Lots of great tools on this app. They have clinical practice guidelines. They have all of our local antibiogram data, which is really important when we're prescribing antibiotics to know what our local resistance patterns are. And then recently we added the Penicillin Allergy Delabeling tool onto the First Line app. And so if you go into guidelines and scroll down, you can see the Penicillin Allergy Delabeling tool at the bottom there. And this tool is a fantastic tool. It was created by a group of allergists out in BC who essentially acknowledged that, you know, allergists are rare and most clinicians don't have access to IV specialists or immunologists to be able to assess or properly assess allergies. And so these allergists out in BC wanted to create a tool that was easy to use, that any clinician, non-allergist, could use to help work through reevaluating penicillin allergies for their patients and help obtain that comprehensive history that we need to determine if a true allergy exists or not. So it's a really easy point-of-care risk assessment tool. It takes literally 1 to 2 minutes. You can pull out the tool and walk through the questions with your patients, and it literally guides you step by step the questions that you would ask your patients to obtain that comprehensive history to determine the likelihood that a true allergy exists. So once you get to the end of that questionnaire, it will say this patient is either low risk of having a true penicillin allergy, and you are safe to delabel based off of that history alone, or if you need further reassurance that a true allergy doesn't exist, or if your patient needs further reassurance that a true allergy doesn't exist, you can provide them with an amoxicillin test dose challenge, and it guides you through how to do that. On the flip side of that, if they're not low risk and they're deemed to be more moderate to high risk, it'll stop you right there and it'll just flag you and say, possible allergy, refer on to an allergist. So this tool only identifies our low-hanging fruit, our patients of low risk of having a true allergy. And you can see that I've kind of highlighted, if you are wanting to do an amoxicillin test dose challenge for our patients who are low risk of having a true allergy, you can click on the protocol and it walks you through how to do that. It is very easy to do. For the patients that you're wanting to do this with, all you do is, for adults, you give them a full dose of amoxicillin, 500 milligrams, PO times 1, and then you just monitor them for an hour after. And usually we'll recommend, checking their vitals at 15-minute intervals for, the 60 minutes, and if there's no reaction, then you can send them on their way. And this is really safe to do. For patients who are low risk of having a true allergy who undergo amoxicillin test dose challenges, there are allergists out in BC who do this type of thing virtually. And I know Dr. Fong has said, when we do test dose challenges in low risk patients and we have them kind of sit and wait for the 60 minutes to make sure they don't react, this would be very similar to a patient coming in and receiving a vaccine and having them wait in the waiting room for 15 minutes, making sure there's no reaction. So it is a very safe procedure. If you are going to be doing this, or if this is something that we're going to be encouraging our physicians to do within our practice sites, they do have to be prepared to manage anaphylaxis because that is obviously worst case scenario. I'm not aware of any literature that has shown patients to have anaphylactic reactions once they are deemed or categorized to be low risk and receiving test dose challenges. I'm not saying that it never is going to happen, but you do need to be prepared to manage anaphylaxis in case it does. And so there is a one-pager on how to do that, and basically making sure you have epinephrine on board would be important to be able to manage that appropriately. So this is what that would look like at the end of that tool. It'll flag you and say very low risk of having a true allergy, no action required, may prescribe penicillins again, or you can do the test dose challenge. Or if they're moderate to high risk, once again, as I said, it'll flag you and say possible allergy and just avoid, refer to an allergist for further assessment. So if you get to the end of that tool, and as a clinician, you have a patient in front of you with an infection, and you think that there might be a possible penicillin allergy, but you still really want to use a beta-lactam because you do think that that will be our best choice, that is the most effective. You don't necessarily have to avoid all beta-lactams just because a patient has a possible allergy. And so there's another nice risk stratification tool available on that penicillin allergy delabeling tool, and it kind of walks you through that. And so as you can see, even in the high-risk category, so these are patients who have either a confirmed allergy by an allergist, a confirmed penicillin allergy by an allergist, or patients who have reported anaphylaxis to a penicillin, you can still safely use a beta-lactam as long as it has a different side chain. And so that brings us into talking about cross-reactivity between our beta-lactams. And so for those of you who don't remember what all of the beta-lactam antibiotics are, I thought I'd quickly review that for us all. So our beta-lactam antibiotics include our group of penicillins. It includes our cephalosporins. It includes our monobactam, which we never use in practice, and then our carbapenems as well. And so you guys, most of you should be familiar with these antibiotics. They are called beta-lactams because they all share a common beta-lactam core ring structure. And then they are further differentiated by the different side chains that are attached and circled in red. So when we talk about cross-reactivity between beta-lactams, what do I mean by that? What I mean is that if a patient is reporting an allergy to penicillin, what are the chances of them reacting to other penicillins like amoxicillin or cloxacillin or piperacillin? That's what I mean by cross-reactivity. So specifically, cross-reactivity between penicillins is a class effect, meaning if a patient has a true penicillin allergy, we should be avoiding all penicillins within that group. And this is because the antigenic properties are due to similarities in that core beta-lactam ring structure along with the side chains, okay? If, on the other hand, someone is reporting an allergy to a cephalosporin, cross-reactivity between cephalosporins is not a class effect. So someone who is reporting an allergy to a specific cephalosporin, that doesn't mean that we have to avoid all cephalosporins. That just means that we would have to avoid cephalosporins or other beta-lactams that share similarities in their side chains. And this is because the antigenic properties are due to similarities in the side chains and not that core structure. Now, cross-reactivity between penicillins and cephalosporins is primarily due to similarities in the side chains once again, and not due to similarities in that core structure. So someone with a true penicillin allergy, once again, a cephalosporin with a different side chain can be safely administered. And then cross-reactivity between penicillins and carbapenems is very low. So in general, when we talk about cross-reactivities between our beta-lactam antibiotics, overall, it's very low. But specifically, cross-reactivity between penicillins and cephalosporins is less than 2%. Between penicillins and cephalosporins or carbapenems, that cross-reactivity is less than 1%. The cross-reactivity risk is highest when these molecules share similar side chains. And of note, and this is an important note, cefazolin is not expected to cross-react with any penicillin or cephalosporin because it's such a unique molecule and it doesn't have a similar side chain compared to any other beta-lactams that we have available here in Canada. So unless the patient is specifically reporting an allergy to cefazolin, we do not need to avoid cefazolin in other beta-lactam allergies because it is such a unique molecule, we are not expecting it to cross-react or for that patient to have a hypersensitivity reaction. So you might be wondering, how am I supposed to know which antibiotics share similar side chains? And we don't have to memorize this. There are great resources and tools that can guide us with this. And the penicillin allergy delabeling tool has guidance around that. So if you see at the bottom, there's a link that you can click on penicillin and beta-lactam allergy management. There's a section around beta-lactam cross-reactivity. You would just click on the antibiotic that a patient is reporting an allergy to, and it'll give you all of the beta-lactam antibiotics that have similar structures or similar side chains and indicate that risk for cross-reactivity. And then it'll further break it down and show you all of the beta-lactams that are unique or have different side chains and have very little risk for cross-reactivity. Bugs and Drugs also has a nice chart around this as well. The last thing that I want to share with you is this journal article that was just published April of this year. And specifically, it looked at cefazolin versus second-line antibiotics for surgical site infection prevention after total joint arthroplasty among patients with a beta-lactam allergy. And we know that cefazolin is a first-line agent to prevent surgical site infections for many different surgeries, but specifically after total joint arthroplasties. And patients who are labeled allergic to beta-lactam antibiotics still frequently receive either clindamycin or vancomycin perioperatively instead of cefazolin due to this perceived risk of a cross-reactivity. Even though we know that cefazolin is such a unique molecule that if someone has a penicillin allergy, they should still be able to safely take cefazolin. Some physicians will still choose to use either clindamycin or vancomycin perioperatively because of that concern of a cross-reaction. And so this study wanted to look at what those outcomes were in the different groups. So this was a retrospective review of patients labeled with a penicillin allergy or cephalosporin allergy who underwent a primary total hip or knee arthroplasty. And they wanted to look at the differences in efficacy. Specifically, they looked at surgical site infections within 90 days of surgery. And then they also wanted to look at the safety aspect, and they wanted to see if there was a difference in the intraoperative hypersensitivity reactions. And so they looked at just over 1,100 surgeries. And out of those 1,100 surgeries, remember, these are all patients who are reporting an allergy to penicillin or a cephalosporin. 72% of these patients still received cefazolin perioperatively. The other 28% received clindamycin or vancomycin perioperatively. And what they found was that the surgical site infection rate for cefazolin was 0.9% compared to 3.8% in the patients who received clindamycin or vancomycin. And this was statistically significant with a relative risk of 4.3. So that means that of the patients who reported an allergy to penicillin or cephalosporin and underwent some sort of total joint arthroplasty, for the ones that received clindamycin or vancomycin perioperatively, they had a 4-time higher risk of surgical site infections postoperatively compared to cefazolin. In addition to that, there were no differences in hypersensitivity reactions between the two groups. And in fact, the cefazolin group had only 2 hypersensitivity reactions. One of them was a cutaneous reaction, and the other one was a self-reported reaction without any other supporting symptoms. So that just highlights the point that cefazolin is safe to use in patients reporting an allergy to penicillin, and it is more efficacious with less harms associated with this. And this also just re-emphasizes the point that when patients carry a label of penicillin allergy, that can expose them to more broad spectrum or less effective antibiotics, and that can increase the risk of harm. So just kind of tying that all together. So really my take-home messages for today are that, number one, penicillin allergies are commonly reported. The vast majority of people, 95%, are found to not actually be allergic. And of those 5% who are actually allergic, most of them will have lost that allergy if they've avoided penicillins or similar beta-lactams for at least 10 years. We know that there's real risk and harm if a patient is mislabeled with a penicillin allergy, and so the penicillin allergy delabeling tool is a great way for non-allergists to reassess or reevaluate that allergy and determine who is low risk versus who is high risk of having a true allergy and who should be referred on to an allergist for further assessment. And when screening your patients and documenting a penicillin allergy, and often this is nursing staff who are filling in those allergy forms, I think one of the most important things that nurses can do is when they're speaking with patients and filling out those allergy forms is making sure you're doing that comprehensive history and including details around that reported reaction. And you can certainly use tools like this to try and tease out if you think this patient has a true allergy or not. And if you don't think a true penicillin allergy is present, then advocate to the physician or the MRP for delabeling that patient and removing that penicillin allergy so that we're not potentially exposing these patients to less effective antibiotics and increasing their risk of harm. And the other thing that we can all do as clinicians, pharmacists, nurses, is help educate our patients around this topic, because I'm sure most patients don't know that, despite them thinking they have an allergy, likely a true allergy is not present, and likely most of them can safely take penicillin. So I'll leave it at that, and I'll stop sharing my screen. And I will open this up for questions. I'm also going to stop the recording at this point as well.